Good afternoon, everybody, and welcome to today's webinar. We have Dr. Lafian with us, and I will let her introduce herself. Dr. Lafian.
Thank you so much. This is awesome. It's so nice to see so many people have already logged on. I am a new community rheumatologist, new to this community. I just actually started my practice here in Glendale on March 1st. I am located on the Glendale Adventist campus, and I'll give you more information at the very end. I did my fellowship training in rheumatology at Loma Linda University, and then I practiced for about a year, a little over a year in Covina, and then before moving here and starting my own private practice. So I'm really happy to be in this community. I'm really happy to serve this community. This is where I was essentially born and raised. I went away for a few years to do my medical training and all of that, and have come back here, and it's so nice to be back home. All right, so I will start the presentation. So a couple ways we can do the questions is if something comes up that you feel like you might forget by the end of the presentation, you can put it in the chat box and we can kind of come back to it. Or you can hold the questions for the end, and then I'd be happy to take some questions. So I initially had planned to do a two-part talk, the first part on osteoarthritis and the second part on osteoporosis. But while I was putting together the slides, I realized there's quite a bit of content. So if we don't get to the osteoporosis part, maybe I can do another series with you guys. But if we do get to that part, then that'd be great. We'll cover all the information. And that way, if you guys have any questions about either topic, feel free to ask at the end. I also have my email address at the end of the slides as well. And so you can also email questions, or if you want to call in, and, I'd be happy to see you as well if you need me. All right, so the first section is on osteoarthritis. So here's the outline for the osteoarthritis, for actually the talk in general. So we'll initially talk about osteoarthritis and the pathogenesis. So what is it that causes osteoarthritis? And then I'll hit on the different sites in the body where one can get osteoarthritis. So obviously you can get osteoarthritis in any part of the body, but the most common parts are what I'll talk about. So the hip, the knee, the hands, and then for the hands, there's also, an entity that's a little more aggressive than just simple osteoarthritis, and that's called erosive osteoarthritis. So we'll talk a little bit about that. And, as we go, I'll kind of try to include some treatment modalities as well. And then for the osteoporosis piece, we'll talk about how one is diagnosed with osteoporosis, what are some risk factors to develop osteoporosis, what are the treatment options that are available, and then some lifestyle modifications like what you can do to improve your risk, to improve your outcome if you do have osteoporosis. All right, let's get started. So osteoarthritis is on a continuum. I'm gonna just move the list here, sorry. So the primary causes of osteoarthritis are joint injury, trauma. So this could have happened, anytime in your life, a trauma, a fracture, a ligamentous tear, or something like that that you may have had when you were in your young adult years or even in your childhood years. And in turn, because of that trauma and injury, over time, you could get osteoarthritis in that particular joint. But in addition to that, it's kind of on a continuum in that because of the joint injury or the trauma, your biomechanics change. So the way you ambulate changes. And then over time, as well as we age, our joints change. So the content of the joints, the collagen, the fluid in the joint changes. And then you get more wear and tear of joints as well. So you get narrowing in the joint. And then sometimes metabolic derangements can cause it. And by that, I mean hormonal imbalances, things like thyroid disease, things like calcium deposition, and things like that. So as far as secondary causes, so in general, we, at least when we were taught, years ago, we were taught that osteoarthritis was a disease that was not inflammatory. It was an arthritis that didn't have, wasn't a traditional inflammatory arthritis. So, and you juxtapose that to something like rheumatoid arthritis, which is very inflammatory. It's immune system mediated, and the joints become inflamed, become swollen, right? And so, but now as the research progresses, we find that there are components of inflammation in osteoarthritis as well. And again, like I mentioned earlier, sometimes calcium signaling or calcium deposition can cause it as well. And so what happens as far as the outcomes in the joints? So you get joint tissue damage, and that in turn causes pain and pain sensitization. And then osteophytes. What are osteophytes? So that is essentially new bone growth. So the body tries to compensate for the joint space loss, for the joint narrowing. And over time, as the, if the osteoarthritis is very severe, you have bone on bone grinding. We hear that term bone on bone a lot. And then the body in turn will remodel and make new bone. So new bone growth. And I'll show you some x-rays to demonstrate that concept. And then, and part of this, but next, line here with the bone marrow lesions, that ties into this inflammatory or inflammation, wherein if an MRI is done on a patient who has osteoarthritis, you will find bone marrow lesions or bone marrow edema. So that also gives us clues that osteoarthritis has an inflammatory component to it. So, and if there's anything, while I'm going along that seems too complicated or too medical terminology, please let me know and I'll clarify that as well, because I want this to be pretty clear and to be educational for you all. So, as you can see here, osteoarthritis isn't just a focal involvement of your joint. It's a disease of the whole joint. So the soft tissue structures, are impaired. The synovium is essentially the lining of the joint. Every joint has a synovial, covering. The meniscus, and so you actually get here, you see the damaged medial meniscus. The bone, obviously, where you get new bony overgrowth. This is that osteophytes that I was referring to, where the bone starts proliferating more at the area where it's getting more and more injured. And then the cartilage as well. So this isn't just, the pain that is caused by osteoarthritis is because you have a lot of things that are involved in the joints. So, sorry, I was just looking in the chat box. All right, so as far as, all right, so as far as hip osteoarthritis, how do we diagnose hip osteoarthritis? So the symptoms usually that go hand in hand with hip osteoarthritis is a feeling of pain, aching, stiffness, or a restriction in movement. And this is very important here, that usually osteoarthritis pain that's in the hip is felt deep in the groin, in the anterior groin. So that's one thing I'll commonly ask my patients when they tell me, oh, I have some hip pain, and I think it's osteoarthritis. Well, sometimes the pain is, not in the deep anterior groin. Sometimes it's a trochanteric bursa issue, so this is pretty common where you'll feel a deep ache in the anterior groin area. But, you could also feel the pain in the anterior or lateral, so the side of your thighs, the front of the thigh or the side of your thigh, or even your butt. And then this is really important too, that sometimes knee pain can actually be referred pain from hip osteoarthritis. So it may not be that the knee in and of itself has osteoarthritis, but because of the biomechanics, the hip has joint space narrowing, the hip has osteoarthritis, and because of your biomechanics or your gait or the way you're walking around, your knee starts to hurt. And then another sign or symptom is, if you stand up from a seated position and you're trying to walk, the first few steps are very painful. That is also a sign or symptom of hip osteoarthritis. And usually, this syndrome or, this issue is diagnosed with a combination of clinical symptoms, a physical exam, and then the x-ray. And I've included some x-rays here because I kind of want you guys to be familiar or see what we look at as physicians when we're talking about it. So if you can see here on the bottom right, this is a normal joint space, and that, you know, all around you see this clear delineation between the joint and then the hip socket. So this black space versus here, look how high riding this femur is. The femur bone is very high riding. It's grinding up against the pelvis, and there's no obvious space for that joint fluid to be, right? There's a little bit more space here, but up here, it's very, very tight and narrow and basically touching one another where you're supposed to have this free joint space. Okay. And then what about knee osteoarthritis? So knee osteoarthritis is diagnosed by having knee pain and at least 3 of the following. If the patient is over 50 years of age, if there is morning stiffness in that joint, but it's less than 30 minutes. And this is important because most of the time, if it's more than 30 minutes, we're concerned more about some sort of inflammatory issue, or, you know, it could be something like gout or pseudo gout, or sometimes an infectious joint. So morning stiffness of less than 30 minutes, or usually kind of improves with a few steps or a little bit of stretching or something like that is a good clue as well. Crepitus. So crepitus, what does that mean? That grinding, creaking, cracking sensation, especially when we first get out of bed and start walking, or even when we're in a seated position and we, you know, extend our leg out, our knee out, and you feel that crepitus, that grindy sensation. A lot of patients will also complain to me that they feel that when they're going up and down the stairs. Bony tenderness. So if you feel over that joint and there, you know, it feels very tender, or if there's bony enlargement, you know, over time, you notice that you're getting an overgrowth of bone in the area. That's also another hint. And then no warmth over the joint. And why do we say this? Because usually if there's warmth over the joint, then again, we're more convinced or concerned about some sort of inflammatory issue, maybe gout or pseudo gout or some other arthritis that could, or even infection, you know, could be causing it as well. So usually osteoarthritic joints are cooler to touch as compared to some of these other inflammatory arthritis conditions. And, you know, it's interesting that an X-ray is not necessarily mandatory to make the diagnosis, but it's very helpful. And, but, you know, although sometimes in mild to moderate cases, an X-ray won't show as much progression. And so it may kind of be, the patient's symptoms might be overlooked a little bit. And so in earlier situations where there's osteoarthritis, you don't always need the X-ray to make the diagnosis. If you kind of meet this criteria up here, then there's a high likelihood that you have osteoarthritis in the knee. Okay. So if we do get an X-ray though, what do we see? Again, so we see joint space narrowing, right? And this is important because I think so I added both of these views because this X-ray was taken when a patient was sitting, and this one was taken when the patient was standing. And look what, you know, and the reason why this is really important to do is because when you're sitting, you have that joint is offloaded. You don't really have that pressure of the body and the weight of the body on the joint. When the patient is standing, you notice how much more narrow this medial, this is the middle part of the patient's knee, how much more narrow that joint space is, and how the bones are essentially touching each other as opposed to sitting. There's still a lot of narrowing here, and there's a lot of sclerosis. And, you know, this sclerosis means this white area where there's a lot more white compared to the rest of the bone, but it's a lot more pronounced in a standing view. So it is important when we're looking for knee osteoarthritis to get, you know, seated views, standing views. And sometimes we do this view that's called sunrise view, where the knee is bent, and then they'll take a picture over the patella, the kneecap. So Again, so what we see is joint space narrowing, we see osteophytes, so that new bony growth, we'll see that sclerosis I was talking about. Sometimes new cysts will form there, they're called subchondral cysts. And then over time, as the joint gets more and more damaged, then you see some joint deformities and joint destruction. Okay, so everything that I have, with the exception of what I'll mention, as far as the treatment of the different osteoarthritis, arthritides in the different locations of the body, are actually taken from the American College of Rheumatology guidelines, treatment guidelines for osteoarthritis. So I break them up, or actually they're broken up into non-pharmacologic things that you could do. And the next slide will have pharmacologic things. And what they did was, they looked through all of the evidence in the science and the literature and all the research studies that were done. And based on everything, they came up with a strongly recommended or conditionally recommended columns where they're talking about various treatments. Because if you even, look out there, read about it on the internet, or even TV programs and stuff, there's a ton of different things that are put out there for different treatments for different diseases, right? But this is pretty evidence-based. So as far as non-pharmacologic things, and I'm a big believer in non-pharmacologic things that patients can do. I think that there is so much in our lifestyle that we can do on a daily basis to help a lot of our different diseases, but OA in this particular case is what we're talking about. So exercise. So this is a huge one. Of all of the things that they had looked into, exercise was the number one thing with the most evidence base that helped with pain. And it's kind of counterintuitive, because we think that if the joint hurts and we exercise it, it's going to hurt even more. But truly the data shows that exercising in osteoarthritis is very helpful. These are some examples, like Tai Chi and aquatherapy. Tai Chi was a really big one that they mentioned. I personally love aquatherapy for my patients, and pool therapy. I think it's really, really powerful, because you offload. Again, you don't put pressure on the joint. You're not standing, you're not grinding, you're not, on a treadmill. Let's say if you're running, you're constantly putting that pressure on the joint. But with water therapy or physical therapy in the pool, you don't have that pressure, that gravity on your joint. So it's really nice. Weight loss is another one that's huge, because obviously it makes sense. The less weight you carry, the less pressure you're putting on the joint, especially for the knee and the hip. Cane use actually was strongly recommended. And a really important thing that I'll talk about is if you are using a cane, if you're using the cane properly, because this is really important as well. If the cane is not being used properly, then you can cause other unwarranted, unwanted side effects. And then knee bracing. So knee bracing was strongly recommended to be done intermittently, not to have on for 24 hours a day. Conditionally recommended, essentially meaning that there was some benefit, was heating and cooling. So alternating heating the joint and cooling, like an ice pack or and a heating pad. Cognitive behavioral therapy. This is like it's almost like a mental health exercise that can be done. Acupuncture. I'm a huge firm believer in acupuncture. I personally love it. I think that it's beneficial. And then balance training. So this is really important, obviously, and this kind of ties into most of the time physical therapy, because if your balance and your gait is stabilized, your core strength is stabilized, you reduce your chances of falling and injury and things like that. And then yoga is also a really good one, because it incorporates stretching and things like that. And radio frequency ablation as well was listed here. Okay. So, and this is what, I kind of alluded to this already, but really exercise does decrease pain in osteoarthritis. You just have to start. I say always start gently. Don't go out there if you haven't exercised in a really long time and, think that you're going to go out and walk an hour a day all of a sudden and be fine, because that is going to induce more pain. So slow and steady. If you're not active, you start with, 5 minutes a day of walking, and then incrementally increase that. But and the same goes for every kind of modality that you're going to do. So, there was like a study done in JAMA, which is like a very large medical journal. It's pretty prestigious. And there was significant improvements in pain as far as patients who were doing regular either physical therapy or a gentle exercise program. And a lot more but efficacy than just weight loss alone. So yes, weight loss is very important for osteoarthritis, but regular physical therapy and a gentle exercise program is much more helpful. So, obviously you'll have less pain, more function. And so, move it or lose it. So that's a little thing I put there. And so this, sorry, I keep having to move the screen around because I see a lot of the participants on the screen and that blocks off certain parts of my page. But, on the bottom of this slide, I recently discovered that the Pasadena Rose Bowl Aquatics Center has pool therapy and a heated pool. And I actually referred a couple patients there recently. They accept Medicare, and you can actually, if you use that link, you can schedule yourself. I believe you just provide them with your insurance information, and then they have aquatherapy classes, which I think is really cool. Okay, so like I mentioned a couple slides up, cane use. This is very, very important. If you are using a cane, are you using it correctly? So you need to use the cane in the opposite hand to the affected knee or hip. So if you have osteoarthritis in the left knee, you need to hold the cane in your right hand. So that's very important. The second thing that's really important conceptually is that the cane height needs to be ideal, and it needs to be correct as well. So the cane height needs to be to your distal crease, your distal wrist crease. Because, if you see here, this is a little bit higher up, the patient's elbow is flexed more than that 30 degrees, that your elbow needs to be flexed at about 30 degrees. So this is too long, and then this is too short. The patient is hunched over. This is going to cause a lot of other issues in the back, the hips, the hamstrings. So, and then also going up the stairs. So how do you go up the stairs if you're using a cane? Again, you're holding the cane on your opposite hand. So if your left knee is affected, you're holding the cane on your right hand. You go up. This is up with the good, down with the bad. I kind of put this in here as an easy way to remember. You go up the stairs with your good leg first, or your good foot. So if your left knee has osteoarthritis or your left hip has osteoarthritis, you're holding the cane in your right hand, and you're going up the stairs with your, the first step you take is with your right leg. So, and then when you come down the stairs, you put your left foot first. So downstairs you initiate with the bad foot first, the bad leg first. Okay, so what about medications? So as far as medications go, they strongly recommend oral NSAIDs. So these are the non-steroidal anti-inflammatories. There's a lot of them out there. These are some: ibuprofen, naproxen, celecoxib, diclofenac. But, be very careful, because a lot of them kind of, sometimes we get the trade name or the generic name, and we kind of confuse them, and we then realize I've had many patients come to me with different bottles, and they're taking two different types of NSAIDs, so that's not good. So be very careful with that. So oral NSAIDs are strongly recommended for hip
Still outrageous.
osteoarthritis. Was that a question? Sorry. Okay. And then topical NSAIDs, so diclofenac gel, or also known as Voltaren, which is now available over the counter. That's also strongly recommended. And then joint injections. So steroid joint injections are very helpful. They are strongly recommended for hip and knee osteoarthritis. A lot of the studies basically showed that there was a lot of improvement in pain in the joint, but that improvement plateaus off at about 26 weeks. To be honest with you, that's much longer than I see in practice. A lot of times patients will say it helped a little bit less than that 26 weeks. But, we have to really take caution in like consistently injecting the same joint, because the cartilage will weaken over time in patients who get repeated injections. So we have to be really careful and mindful of that. And then conditionally recommended is Tylenol or acetaminophen. That's the same thing. A medication called duloxetine or Cymbalta. So I don't know, some of you may be aware of this medication. This is technically considered an antidepressant, but it's also used in patients who have, pain syndromes and fibromyalgia. And the reason why it may be helpful is, and in cases that it can be more helpful, is in patients who have other medical problems where they can't take NSAIDs or Tylenol or some of these other medications. If they have, for example, ulcers, gastric ulcers, or they have a history of gastric bleeding, or they have a history of kidney disease. So that medication, the duloxetine, might be helpful in patients like that who have a lot of pain because of osteoarthritis. So, I kind of mentioned this earlier. A word of caution about NSAIDs, those medications like ibuprofen, Motrin, Aleve, naproxen, Mobic, diclofenac. So long-term use at high doses, and not even high doses, sometimes in patients who, have multiple risk factors, may not be a good idea. So really talk to your doctor before taking these regularly. I have seen patients who have who come in with like big time kidney disease, kidney failure, renal failure, because they were taking multiple rounds of NSAIDs a day, or taking the medication too frequently for too long because of pain, or, and there's a good, as far as us as physicians, we need to take this into consideration, is the risk of GI toxicity. So if a patient has ever had a complicated ulcer, meaning an ulcer in the stomach or the intestines that has bled in the past, especially recently, or if they have other risk factors. So if you're above the age of 65 and you're taking high doses of NSAIDs, or if you also use aspirin or other blood thinners, like Plavix or warfarin or anything like that. So there's a high risk of GI bleeding or GI toxicity. So please be mindful of that. But I also put in here in the table that, it can affect the heart as well. A lot of this use long-term can increase the risk of MI, myocardial infarction, as heart attacks, strokes, and things like that. Can also mess with the kidneys. Again, I'm not saying this to scare you. It's not, meant to be scary. Once in a while, taking NSAIDs is not going to do this, but this is for patients who are taking it repeatedly, day in and day out, and have risk factors or, other comorbidities. So please talk to your doctor if you're doing that. All right, so other treatments that were mentioned in the list in the American College of Rheumatology guidelines for hip and knee osteoarthritis in particular were these where they kind of mentioned that they looked at the data and it was inconsistent. So what does this mean? Usually I take this with a grain of salt. In some patients, they can see great benefit in using these things, and other patients not so much. And so my advice is usually I'll tell patients that maybe the improvements were anecdotal, but they help patients. But this is, glucosamine and chondroitin has been around for a really long time. They're supplements that are out there. You can literally get them at most health food stores. But again, the data is inconsistent whether it helps or not. Hydroxychloroquine is actually a medication we use in rheumatology for a lot of other connective tissue diseases, lupus, things like that. And so definitely they say, to not use this medication for hip and knee osteoarthritis. PRP injections have been used a lot more commonly in the recent few years. And again, the mention is that the data is inconsistent. I have seen some patients greatly benefit from PRP injections. But again, the data isn't fully out there yet, and I'm sure there's going to be more studies in the future. Same with stem cell injections. Gel injections, I think, are done a lot more often than probably PRP and stem cell, and a lot of orthopedic docs do it. I also do them in certain situations or certain cases. Again, the data isn't the strongest, but some patients respond really, really well. So I think it's on a case-by-case basis that needs to be decided. And sometimes patients are not eligible for steroid injections because they have really bad diabetes, for example, their blood sugar spikes when they get steroid injections, or, for whatever other reason, then maybe we can try a gel injection. And what about surgery? So there's no optimal time to refer a patient for joint replacement or joint surgery. And unfortunately, there's not a simple test to determine who's going to benefit from surgery the most. So usually in the studies, we find that whoever had the worst of pain or functionality before the surgery gets more benefit out of it after surgery. And then one other caveat is that if a patient has other poorly controlled pain or pain syndromes like fibromyalgia or chronic pain or anything like that, those patients tend to do a little worse after, as far as like pain relief goes. They may not feel as much of an improvement in their surgery as compared to someone who doesn't have any other pain syndromes. Okay, so moving on to hand osteoarthritis. And wow, I'm talking a lot because we're already at 12:35. Okay, so hand osteoarthritis, the symptoms of it are joint pain, eventually can lead to joint deformity. Not everybody gets joint deformity, but it kind of depends on the severity of the patient. And then you can also notice decreased grip strength. So you have difficulty opening doors, opening jars, doing certain housework, or even just, holding a fork to eat sometimes is difficult. You can develop nodes, and the nodes here, so the ones that are located on the most distal joint, the little tiny joint that we have at the edge of our fingers, is called a Heberden's node. And then the one in the middle and these joints here are called a Bouchard's node. And then this is your CMC joint. The reason they highlighted it is one of the most common areas to get osteoarthritis is in this joint here. And I plugged in a little X-ray to see that here there's so much more destruction. There's narrowing here of this joint space. You don't see, as compared to here where you see a clear delineation of the joint, there's more black, there's that free space. You don't see that here. The bone is touching bone. It's a little more angry looking, more sclerotic. So you see a more white. And so that's evidence of CMC, which is carpal metacarpal arthritis, osteoarthritis. That would be around here. And again, you can get stiffness in the hand and you can get crepitus, that same creaking, cracking, grinding sensation in the joint. And so what are the non-pharmacologic treatments that are strongly recommended? Again, exercise, you see this as a common theme. CMC bracing was also strongly recommended here. That's just a brace particularly for this CMC joint here. Again, with bracing, I say always, consult with a OT, an occupational therapist for the hands and stuff. A physical therapist would be good for the knees and the hips. But I mean, you're not going to brace the hip, so for the knee, but don't put it on for 24 hours a day. You need to give your joint a little rest with the brace as well. Conditionally recommended, again, was the alternating the heating and cooling, the cognitive behavioral therapy, acupuncture, again, I'm a big fan of, and paraffin dips. Actually, a lot of occupational therapy centers will offer like paraffin dips, ultrasounding, and I find that it's really helpful to do hand occupational therapy for osteoarthritis patients of the hands. One thing that I will say about that occupational therapy is a lot of times we, think like, okay, what is it that they're going to do? They're just going to have me do some stretches. I can do that at home. But what I love about occupational therapy is that they will guide you in telling you certain tips and tricks you can do in your activities of daily living that will make your life easier and propagate, less pain, but less joint deformity. For example, instead of squeezing your tube of toothpaste, like this, they'll advise you, this is like just one example. They'll advise you to place it flat on a table and use the palm of your hand to squeeze the toothpaste tube like that, so that you're not propagating that squeezing motion and stuff. So that's just a simple, example, but there's just so many different things that they can help you with. So as far as medications, again, this is specifically for the hand because they looked at the evidence in different parts of the body. They did the hip and knee, and then they did the hand. Oral NSAIDs, again, were strongly recommended. They felt like that was the one that provided the most pain relief. But remember what I said about, if you have any contraindications. Conditionally recommended was topical NSAIDs like diclofenac gel, also known as Voltaren. Steroid injections into the joints that were affected. So at times, yes, we can inject like the CMC, we can inject even like specific, these little small joints of the hands as well, but it's not strongly recommended. It's conditionally recommended. Tylenol as well. And then, and I find too that I've told my patients, there have been studies that show that a combination of an NSAID and a Tylenol sometimes is as strong or as efficacious as providing pain relief as as a narcotic medication would be. So some patients, if they don't get enough relief with the NSAID, I'll tell them to take a Tylenol as well. And then there is an improvement in pain. Duloxetine again, or Cymbalta, I mentioned, why this is helpful. And then topical capsaicin, creams, they sell these again over the counter. It was conditionally recommended here. Okay, and what is erosive osteoarthritis of the hand? So erosive osteoarthritis is a little bit more severe than classical osteoarthritis. It has components of inflammatory, arthritis. So on a spectrum here, OA is just like your classic osteoarthritis that we talked about with the Bouchard's nodes and the Heberden nodes. This is erosive osteoarthritis. And here at the end of the spectrum, we have rheumatoid arthritis. So erosive osteoarthritis is somewhere along the spectrum where you're starting to pull a little bit more towards the inflammatory arthritis or the rheumatoid arthritis side. So this one, patients will tell me they wake up in the morning, they feel extremely stiff. And sometimes the stiffness lasts for over 30 minutes. Sometimes their joints actually swell up. So that's the difference between just a basic osteoarthritis and a more progressive immune mediated rheumatoid arthritis is that, joint swelling occurs. So the joints will actually swell up. And when a physician like myself, will examine the joints, they will feel like the synovium inside is swollen. So in erosive osteoarthritis, I do have some patients who will complain about swollen joints, painful joints. And what happens is the symptoms in wherever you're affected, within whichever joint of the hand will get worse and worse and worse over some several years. And then eventually the pain and the progression will plateau. And so see the difference here in the x-rays of an erosive osteoarthritis patient. You actually get joint deformity from within. So on an x-ray, you see that your joint here is deformed. We call it, the classic thing that we look for in erosive osteoarthritis is a gull wing, because it looks like the wings of a gull, the gull wing erosion of the joint. It's kind of like an M in the joint. Same as here, you see the Z kind of like a zigzag here. It's supposed to be nice and smooth, but here you have these deformities, the joints are kind of slipping on one another. So this is more like erosive osteoarthritis. And so what do we do? How do we treat it differently? The evidence isn't that strong for hydroxychloroquine or Plaquenil. There was really not that much pain reduction when they did a couple trials to test for this medication in erosive osteoarthritis. But I have had quite a few patients who I've put on hydroxychloroquine because they have that classical, swelling pain, excuse me, and they've actually benefited a lot from this medication. I love, I'm an integrative rheumatologist, which means I love lifestyle medicine and other things that we can do, other modalities we can incorporate outside of just conventional medications. So, I need to mention the herbal medications for OA. However, I want to, give this caveat that herbal medications are can be just as powerful as regular medications, pharmacologic medications your doctors are prescribing. So you need to be very, very careful in its interactions with one another. Like, for example, the top, herbal medications for osteoarthritis are boswellia. Turmeric is very anti-inflammatory, and cat's claw, for example, right? But in all three of these, you need to be very careful if you're on a blood thinner, like Coumadin, warfarin, Eliquis, Plavix. There's a lot more out there, like Brilinta, right? So because it can cause worsening of bleeding or messes with the platelets. Occasionally, the turmeric especially can cause upset stomach. And if you can't take, let's say, for example, turmeric, because you're on Coumadin or warfarin, a little bit of it in your food is not going to really mess with your medication much, as long as you get the root and you add black pepper. The black pepper helps the body to absorb the turmeric much better. And I like this directory. It's the Memorial Sloan Kettering Cancer Center directory. They have like a whole branch of medicine that they, or a clinic. It's an integrative medicine clinic. If you go on this link here, you can search all sorts of different herbs and you can see what their side effects are. You can see in which situations you should avoid taking those herbs and things like that. But always, 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 please ask a doctor before you implement any herbal medicine or supplements into your life, because there can be interactions with some of the medications you're taking. Okay, so we are at 12:45, so we can stop and do questions and go through questions if you guys have them, or we can run through osteoporosis as well and then take a couple questions after that. What do you guys, Sarah, what do you think we should do?
I think let's touch on the osteoporosis, and if someone has a question, put it in the chat.
Okay.
Put in the chat.
Okay, so let's do that. So I'll go through osteoporosis as well. Okay, so now we're completely switching gears, right? So osteoarthritis we spoke about. Now we're talking about a completely different disease entity, and this is called osteoporosis. What does osteoporosis mean? So this is a normal bone. You can see that the bone density is much better here than it is in here, and also much better than it is in here. And over time, the bone, can become more porous. It essentially becomes more porous. And because it's more porous and less dense, it's more prone to fracture. So why do we care so much about osteoporosis? We care because it puts patients at risk for fracturing. If you're fracturing a hip, you're out of commission for quite some time. You end up in the hospital. You need one surgery. To, you can get complications from surgery, from being in the hospital, from being immobile. You can get blood clots and all sorts of things, right? And so the reason we care so much about osteoporosis and treat osteoporosis is because we don't want you to fall and have like a minor fall and have a fracture. So as far as, defining it, we do this T-score is measured on a bone density, and I'll show you in a couple slides what that looks like. But we do a bone density test, which is also called a DEXA, DXA, a DEXA scan, and then that will give us a quantification of your bone mineral density in your spine and your hip. And from there, we can extrapolate, how strong or weak your bones are. So if you are at -1 or better or more, you have a normal bone density. And this value that they create compares you to people of your own age group. So if you have a bone density of -1 to -2.5, you are considered osteopenic. So you have a little bit of bone density loss. If you have a T-score of -2.5 or greater, so -3, -3.5, -4, you are considered osteoporotic. Now, another component to this is, let's pretend that we don't have a bone density done on you. And God forbid you have tripped over a rug and fallen and had a hip fracture at some point in your life. You, by definition, have osteoporosis. So it doesn't matter if your bone mineral density is in that osteopenic range, because you had a minor trip and fall, or, we call it a ground level fall for you're standing, you're at standing height, but you have a little fall or an injury, then you, by definition, are considered as having osteoporosis. And that's something that I find that a lot of primary care doctors, or even patients, doctors in the hospital and stuff, don't convey to their patients as much as they should. So again, just to reiterate, a clinical diagnosis of osteoporosis can be made by the presence of a fragility fracture. So this means that you have, had a compression fracture in your spine. You have fallen and hurt your hip and fractured your hip or your wrist, your humerus, your arm bone, your ribs, or your pelvis. without even having a bone mineral density. So, and I define fragility here. What does that mean? It's either spontaneous, so I've had a patient where, she was putting the sheets over her mattress and she had a compression fracture of her spine. So it depends on your bone density. If it's really weak, something like that can happen. So it's either a spontaneous fracture or from a minor trauma. And then, a major car accident or something doesn't count. And then, or, and the other thing is, or you get a bone density and your bone mineral density is less than 2.5, less than or equal to 2.5, negative 2.5. All right. So, and I put this here again, just as just to hone in on things. Normal bone density is negative 1 to 1. Low bone mass or osteopenia is between negative 1 and a negative 2.5. When you get to negative 2.5 or less than that, then you are considered osteoporotic. And then technically, severe osteoporosis would be, much worse than that, negative 3, negative 3.5. And again, especially if you've had a fragility fracture, at least one, but sometimes patients have more than one fragility fractures. So what are some causes for low bone density? So, obviously the number one thing is aging. As we age, our hormones change. We go into menopause. That's the number one cause, probably, I would say. But some lifestyle factors are smoking, excessive alcohol use, physical inactivity, and poor nutrition, right? And then also some medications can also put you at risk for osteoporosis. Some of these things are steroids. As a rheumatologist, I rarely do prescribe steroids, but I don't like steroids because this is the number one reason I don't like steroids, because it can induce osteoporosis or a rapid bone loss in my patients. Certain immunosuppressant medications like cyclosporin and things like that can cause it. Certain cancer medications can cause it as well. And then other diseases like hyperthyroid, anytime your metabolism is a rapid state, like your thyroid working in overtime or your parathyroid is working in overtime, that can also cause you to rapidly lose bone. Certain things like celiac disease, this is inflammatory bowel disease, not to be confused with IBS, but this is IBD, this is an inflammatory bowel disease, or even rheumatoid arthritis. And again, this list is not exhaustive. So treatments, there are so many different treatments now. Back in the day, we relied mostly on this group of bisphosphonates, alendronate, or also known as Fosamax. But look at the list, it's exhaustive. I'm not going to go through them one by one. And there's different formulations too. In the bisphosphonate category, you have an oral medicine, you have an IV medicine just once a year. In these other categories, this is sub-Q every 6 months. Evenity is monthly for 12 months, and then you have to change therapy. These other medications are daily injections for 2 years. And again, you have to change category. So it depends on your particular case. I can't say, just by a simple question of what medication is right for you. It depends whether you have kidney disease. It depends whether you have a history of fractures, fragility fractures. Have you ever fractured your spine, et cetera, et cetera. So it all just depends on your particular situation, but there are a lot of different treatments. The number one important thing that I want to highlight here is if you are on any of these treatments, especially Prolia, Evenity, Tymlos, Forteo, do not ever stop the medication abruptly without talking to somebody about starting another medication, because the bone that you have built will rapidly decline and you can even lose more bone than you once started with. So it's really important not to just stop taking one of these medications because it either caused a side effect or you don't feel like taking it anymore. And a second thing, even if your bone density goes from osteoporotic range and then a year later, your doctor decides to get a bone density done, a DEXA scan, to see if you have had an improvement, and you, for example, took Prolia twice and you went from osteoporotic range to osteopenic range, it doesn't mean that you no longer have osteoporosis. So yes, that's fantastic. That's great. And we want that to happen. But it doesn't mean you can just stop treatment then because now your bone's much better. Treatment should continue. And again, if you want to change your treatment, that's a different discussion. But you don't, just because you improve from one category to an improved category like osteopenia, or from osteopenia to normal bone density, doesn't mean that you need to stop treatment. You should continue treatment. And as far as what you can do, diet, things like that. So I am a big proponent of, or I encourage eating calcium-rich foods as opposed to taking in too much calcium as a supplement. Yes, in severe cases, I do still tell patients occasionally to take, a calcium supplement, at least 1,000 milligrams a day of Oscal or something like that. But I would much rather you focus on taking in calcium-rich foods. Because there's an argument that a lot of cardiologists especially make in the cardiology field, that taking too much calcium supplementation can actually deposit in the arteries of the heart, and we don't want that to happen. So take adequate amounts of vitamin D as a supplement, but if you can, try to take in calcium-rich foods, a lot of greens, different leafy greens and things like that, certain nuts and beans, okra is great, some of these other things. So if you just Google, I literally Googled these and found them, calcium-rich foods in the images, you'll find big lists like this. And I didn't mention here, sorry, I think I skipped this. Oh, I skipped a lot. Sorry about that. So, okay. And how do we do it? Bone density is done. It's very simple. It's essentially like an X-ray machine, but they have you lie down and then, they check your hip density and your spinal density. And then we get a picture like this that will give us like a graph of exactly, the quantified levels, the bone mineral density that you have. And then they'll based on your values, they'll plug you in on this chart, wherein this is osteoporotic range, this is osteopenic range, and this is normal. It's a very easy, simple test to do. It's not painful or anything like that. And okay, and then avoid smoking, limit alcohol. For women, it's less than 1 drink a day. For men, it's less than 2 drinks a day. Get enough calcium through your diet. Please supplement with vitamin D. A lot of patients have vitamin D deficiency now, but if your vitamin D stores are not repleted, your bone turnover, your bone, remodeling and bone growth, bone development is not going to happen properly. So one, depending on your levels, if it's very, very low in the teens, you might need the once a week 50,000 units of vitamin D for 3 months. If it's, better, but still on the low side in the 20s or, even low 30s, I recommend like a daily supplement of 2,000 units a day. But, monitor that with your physician as well. As far as coffee goes, I hope that you're limiting it to less than 3 cups a day. And exercise. This is very, very important. Even weight bearing exercises is even considered walking. So walking 30 minutes a day is great to do. It'll help you build your bone, it'll help you with your balance, and it'll help you to prevent falling, which can cause fractures. And that is it. This is my website. You can go there. This is our address, our phone number, and if I can be of service to any of you, please don't hesitate to call and ask.
Okay, thank you. I'm going to stop the recording.
Okay.
And